A hearty good afternoon and welcome to the session on recurrent implantation failure. We are glad to have Dr. Sangeetha Anand among us today to help us understand the topic. She will take us through that and more in this session today. Doctor, you have the stage.
Good evening, everyone. This is Dr. Sangeetha Anand, consultant reproductive medicine at Apollo Fertility, Brookfield, Bangalore. Today, I would like to discuss about recurrent implantation failure. What does it mean, recurrent implantation failure? When IVF fails, even after multiple embryo transfer, if patient fails to conceive, that condition is called as recurrent implantation failure. So, for a successful implantation is it means the process of embryo attaching to the uterus. It's a critical step in reproduction. So, for a successful implantation to happen, we need three things. One is a good quality embryo, which is very important. Next is the endometrial receptivity. That means the endometrium should be receptive to attach the embryo, and the microenvironment for the embryo maternal signaling should be conducive. So there are various definitions for recurrent implantation failure. HRA guideline says that when there is a failure to achieve a clinical pregnancy even after 3 unsuccessful transfer of good quality embryos or a cumulative transfer of more than 10 embryos in multiple cycles. There is another definition where British Fertility Society says that the absence of a positive pregnancy test after 3 consecutive embryo transfers. So, whichever be the way, more than 3 failed embryo transfer, we consider as recurrent implantation failure. So, the incidence of recurrent implantation failure varies, but among IVF patients, on an average, around 10 to 15% of patients who undergo IVF fall under this category. So, going which patient we expect to have a failure, or who are all the risk factors? Who are all the patients who can have a failure? So, what are the risk factors? One, we all know it is commonly discussed thing is the advanced maternal age. Age of the women plays a very important role in deciding their quality. So, with advanced age, the quality of the oocyte comes down, and that has an effect on the result. Second is obesity, elevated body mass index. Next is the lifestyle, smoking, alcohol, stress, and the poor quality of life. Next is the severe male factor. When there is a severe abnormality in the semen parameters, again it can lead to a failure. So, as we know, the effect of age of the woman on the fertility outcome. As the woman ages, the quality of the oocyte comes down. So, the advanced maternal age has an impact on fertilization rate, on the embryo quality, as well as on the blastocyst formation rate. The chance of aneuploid embryos increases once the woman's age advances. Next, the effect on obesity on the reproductive potential. Excess body mass index exerts its effect upon conception and implantation through a cumulative impairment of several processes. Same way, in female and male, both it has an effect. There is a decrease in the fertilization rate, decrease in the quality of embryos, clinical pregnancy rate comes down, there is a high DNA fragmentation happening in the sperms. So, obesity has an overall effect on implantation, on clinical pregnancy, as well as on the live birth rate. So, next, coming to smoking. Noxious effect of smoking on pregnancy outcome in IVF. Each stage of reproductive function, right from folliculogenesis, steroidogenesis, embryo transport, and endometrial receptivity, endometrial blood flow, everything is compromised in women who have a habit of smoking. Smoking patients have low estradiol levels during the ovarian stimulation, and smokers require twice the number of IVF attempts to achieve a pregnancy compared to non smokers. Smoking has a negative effect on the endometrial thickness as well as on the blood flow. Same, passive smoking has equally important role to play in fertility as a active smoker. Next, going to alcohol consumption. So, the effect on steroidogenesis, it has an effect. effect on the fallopian tube function, and it has an effect on the uterine cavity as well as on implantation. Alcohol consumption leads to an increase in estrogen and decrease in progesterone level. There is a decrease in the hepatic oxidation of the estradiol and estrone. So there is a decrease in the expression of sex hormone binding globulin in the granulosa cells, and it has an effect on the oviductal smooth muscle cell, decreasing its contractility. So same, it has an effect on the uterine cavity as well. When there is a pre-implantation developmental defect, there is a decreased cytotrophoblast cell proliferation and increased apoptosis. 18% greater odds of failed implantation are seen among women who have a habit of smoking and alcohol consumption. Next, as we all know, stress is very common in people who undergo fertility treatment, especially before IVF and post IVF. Especially if it lands up in a failure, the stress levels are even more. So, IVF failure leads to a higher rate of both anxiety and depression in the immediate period after a failed cycle. Next, the severe male factor. As I said, when there is a severe abnormality, poor quality sperm, it has an effect in recurrent implantation failure, because these abnormal sperms can lead on to chromosomal abnormality. There can be genetic mutations, and there can be DNA fragmentation. As I said, all this has an effect on the embryo quality, leading on to a failure of the whole IVF process. 28% of the sperm cells of the infertile men exhibit DNA fragmentation, compared to only 13% in non-infertile men. So, how does this recurrent implantation failure happens? So, there to achieve a implantation, adequate implantation, various factors are involved. There should be a balance between the T helper 1 and T helper 2 cells. When there is a predominance of T1 helper cells, this leads to a failure. Again, there is an increase in the number of interleukins, cytokines, VEGF, and platelet derived growth factors. All this play a role, plus the natural killer cells. All this leads to a repeated failure. So, when you look at the mechanisms which is involved in the repeated failure, mainly the endometrial thickness, genetic factors, sperm morphology, chronic infection leading on to chronic endometritis, any anatomical defects in the uterine cavity, any immunological causes, and dysbiosis. When you look at the mechanisms which are all involved in recurrent implantation failure, mostly we see aneuploid embryos, genetic abnormalities, severe male factor, severe abnormality in the sperm, any anatomical defects in the cavity like a polyp or a submucous fibroid or intrauterine adhesions or thin endometrium, endometrial thickness, chronic endometritis, dysbiosis, and immunological causes. These are the most commonly involved reasons for a repeated failure. Natural killer cell. As I said, there are two varieties of natural killer cells. One is in the peripheral blood and in the uterine cavity. The events entailed in implantation failure leading to inadequate pregnancy maintenance in RIF mostly are contributed by these natural killer cells. The peripheral natural killer cells, the levels of CD56 dim, CD16 plus cells in women with IVF failure was significantly higher than those who had a successful outcome in IVF. Same like that in the uterine natural killer cells. The density of the uterine natural killer cells in the endometrium for women with recurrent implantation failure after IVF is significantly high compared to the endometrium of the woman who had a successful implantation. Same as I said, the T helper cells. The ratio between the T1 and T2 helper cells and TNF alpha plays a very important role in achieving implantation. The timely shift of the T helper 1 to T helper 2 is of utmost importance for implantation. There should be a predominance of T2 cells. The high T1 cells or a high T1 to T2 ratio is linked to more than 4 times implantation failure rates and pregnancy loss. Similarly, TNF alpha concentration is significantly higher in the group with the embryo implantation failure. Next, going to the autoimmune conditions associated with failure. Women with the recurrent implantation failure, they have a high incidence of autoantibodies. in patients with recurrent implantation failure have a high frequency of presence of antibodies, especially the APLA syndrome. When you look at them, there are three markers. One is anti-cardiolipin antibodies, beta-2 glycoprotein, and lupus anticoagulant. Plus, the presence of antinuclear antibodies in the serum of patients with repeated failures was found to be high. So, antiphospholipid antibodies affect implantation, placentation, as well as early embryonic development and growth. And it has a detrimental effects during pregnancy as well by directly binding to the trophoblastic cells. Next, going to other inherited thrombophilias. Thrombophilias are the conditions where the blood has an elevated level of a tendency to form clots, hypercoagulable state. So when there is a clogging of the blood vessel, when the blood vessels gets blocked with clots, microvascular clogging of the blood vessels in the decidua during the implantation period, leading because of this hypercoagulable state can lead to a failure of the IVF cycle. So there were various studies to find out is there a correlation between various inherited thrombophilias and recurrent implantation failure, and they found a strong correlation between the thrombophilias and failures. Next, going to the dysbiosis. Dysbiosis is an imbalance between the good and the bad bacteria in the uterine cavity. The clinical implications of dysbiosis on female reproductive tract in pregnancy has been achieved. They have found out it is linked to a spectrum of clinical disorders that are related to the female reproductive system. Right from the vagina, when there is a buccal vaginosis, it can lead on to either infertility or a sexually transmitted disease. In the fallopian tube, it can lead on to a chronic pelvic inflammatory disease. It can lead to an ectopic pregnancy, or it can lead to a chronic endometritis. In the decidua, it can lead on to a miscarriage. It can lead to a preterm premature rupture of membranes, and it can cause a recurrent implantation failure. Next, looking at the microbiota of infertile women with recurrent implantation failure. People with recurrent implantation failure might have an altered microbiota in the endometrial cavity, which is usually ignored. When they looked at the microbiota of RIF patient, the women with RIF were found to possess a fairly different microbial communities. That could have been the reason for the failure of implantation. So there should be an abundance of lactobacilli. Low abundance of lactobacilli or the abundance of pathogenic bacteria in the endometrial cavity, in the endometrial microbiota, was found to be associated with a poor pregnancy outcome. So they found out whenever there is a predominance of lactobacilli, the pregnancy rates were better. So non-lactobacilli dominated endometrial microbiota significantly correlates with the adverse outcome. So they found out the in patients who had a repeated implantation failure, the microbial environment was altered. It was not a lactobacillus dominated environment. Similarly, chronic endometritis. The prevalence of chronic endometritis, chronic inflammation inside the uterine cavity, that ranges between 15 to 60% in women with RIF. The incidence is quite high. In chronic endometritis, normally during implantation, there should be an immune suppression. The immune suppression that is requested for embryo implantation is converted to a immune reaction. Because of this chronic endometritis, there is an immune activation which hampers the embryo implantation. Next, as we all know, endometrial thickness. We need to have a good endometrial thickness to achieve a pregnancy. So normally they found out around the endometrium of 8 to 9 mm, the pregnancy rates are good. So the pregnancy rates were low when the endometrium was less than 7%, again when the endometrium was more than 13 mm. So ideal endometrial thickness, what we look for is 8 to 9 millimeter. So the clinical pregnancy and live birth rate is a direct correlation with the endometrial thickness, and it is universally accepted. Next, looking at the uterine cavity abnormalities which could lead on to repeated failure. Mostly small submucous fibroid which is indenting inside the cavity can lead on to a failure. Submucosal fibroids, if if they are present, they are associated with a 70% decrease in the odds of pregnancy and delivery rates. Next, polyps. Polyps. Patients who are subjected to polypectomy had a significantly higher chances of spontaneous pregnancy after polypectomy. Next is intrauterine adhesions. Intrauterine adhesions are seen in around 8 to 10 percentage of women with recurrent implantation failure. So when we do a hysteroscopy, see how the cavity look like, and adhesiolysis, if it is done, it increases the endometrial vascularity, it increases the endometrial growth in the subsequent cycles, and increases the odds of spontaneous conception. Next, hydrosalpinx. Implantation rate and pregnancy rates have been found to be significantly low in women who have hydrosalpinx compared to women who have a normal fallopian tubes. And they found out after disconnecting the patent fallopian tubes, the pregnancy rates and the implantation rates were better in patients with RIF. Next, going to the genetic abnormalities. Several SNPs have been reported to be associated with recurrent implantation failure. Some most common ones are HLA gene polymorphisms, VEGF gene polymorphisms, P53 gene genetic polymorphism. All these have been found to be associated with recurrent implantation failure. Sperm morphology is a very important parameter which plays a role in repeated implantation failure. The potential factors that can lead to sperm DNA damage or fragmentation are because of this IDFI, there can be an altered potentiation. Every function of sperm might be altered, leading on to high oxidative stress, plus the advanced age, plus exposure to chemicals. All this plays a role in achieving a healthy pregnancy. Next, what all tests we do to identify the cause in women with recurrent failure? When there is a repeated failure, we with one IVF failure itself, we go and check where is the issue. So when there is a multiple embryo transfer failures, two or three, then we need to look where is the problem. Either the oocyte, whether the MH is the reason, advanced maternal age is the reason. Next, sperm aneuploidy or the sperm epigenetics is the reason. Next, karyotyping. It's a blanket testing, but higher order RIF needs this. Uterine and adnexal factors. As I said, is there any polyp in the cavity or a submucous fibroid pushing inside the cavity or hydrosalpinx fluid is the reason for the failure? We look at the uterine cavity abnormalities. Next, immunological factors. Immunological like means uterine natural killer cell activity, peripheral natural killer cell, endometrial cytokines. All these are autoimmune conditions like inherited thrombophilias, Apla syndrome. All these are investigated to see if any thrombophilias or autoimmune conditions associated with the failure. Endocrine factors, like usually we check even before the first embryo transfer, we check the thyroid levels and diabetes, prolactin, all this are investigated. What are the therapeutic intervention? What all we do to achieve a pregnancy when there is a repeated failure? So we look right from the beginning of stimulation, look the optimum IVF treatment, optimum stimulation. Next, give them antithrombotic agents. And if there is a suspicion of a polyp or a fibroid, do a diagnostic hysteroscopy. Then, if you suspect chronic endometritis, do an antibiotic therapy for that and immunotherapy. So, optimum IVF treatment requires a good quality embryo and optimal transfer method, and what ovulation induction protocol we followed, and what kind of luteal phase support we gave for the patient. So we move from fresh transfer to a frozen transfer. Compared to a fresh transfer, frozen embryo transfer has always achieved a better pregnancy rate. There is a decrease in the incidence of low birth weight babies. There is a decrease in the incidence of preterm birth, small for gestational age, and placenta previa, placental abruption. So frozen embryo transfers always resulted in a higher frequency of live birth compared to a fresh transfer, especially in women with polycystic ovaries, where high estrogen level has an adverse effect on the endometrial lining and the implantation. Ongoing pregnancy rate and live birth rate were higher in the frozen group compared to a fresh group. Even high responders have a higher clinical pregnancy rate. pregnancy rate and live birth rate in a frozen cycle. Then moving to the which stage of the embryo we transfer. From a cleavage stage embryo, we move to the blastocyst stage. Patient who had a cleavage stage embryo were age matched with patients who had a day 5 transfer, and they found definitely higher pregnancy rate. So cleavage stage transfer was associated with a significantly lower implantation and a clinical pregnancy rate and live birth rate. Whereas in women with a blastocyst transfer, the pregnancy rates were better. So next, going to the embryo transfer technique. Embryo transfer is the final and the crucial step in whole of IVF process. That transfer technique plays a very important role in deciding the result outcome. So various interventions are supported by literature for improving the pregnancy rate. One is doing the embryo transfer under abdominal ultrasound guidance. Second, using a soft catheter so that we don't injure the endometrium. Next, removing the cervical mucus and placing the embryo exactly 1 to 1.5 centimeter from the fundus achieves a good result. Optimum endometrial thickness, which I already discussed. Immediate ambulation of the patient after the embryo transfer has also been found to have a good result. Next, going to the ovulation induction protocols, whether we do a long-acting GnRH agonist protocol or a GnRH antagonist protocol, the pregnancy rates and live birth rates remain the same. There were various studies to find out the difference between the various protocol to tell which gives a better result. The long-acting GnRH agonist protocol was beneficial in improving the live birth rate and clinical pregnancy rate as well as implantation rate, whereas the incidence of OHSS was high in that group compared to the ANTAC protocol. So there is no big difference between the various protocols what we follow for patients with RIF. So it is other than the ovulation induction protocol, as I said, other factors play a role in RIF. Next, preparing the endometrium for uh, embryo implantation. The progesterone has an effect on the endometrium. So, how does progesterone work? It helps to transform the endometrium to a secretory phase. It helps in implantation and early pregnancy maintenance, and it brings about secretory changes in the glands, and there is an increase in stromal vascularity. Other than that, it has an anti-inflammatory effect as well as immunomodulatory effect that helps in the development and maintenance of pregnancy. Progesterone in pregnancy plays a very significant role in establishing an adequate immune environment in the early stage of pregnancy. It exerts its immunological effect, protective effect to maintain the pregnancy by controlling the cytokine production, and it maintains the environment with the predominance of T2 helper cells. So deficiency has been associated with insufficient endometrial maturation and inadequate regulation of the inflammatory cytokines. So support with progesterone may help to establish a sufficient immune response in early pregnancy and prevent miscarriage. So we need to choose the right progesterone. There are various progesterone preparations available: oral progesterone, vaginal micronized vaginal progesterone, injectables are there, and oral progesterones are available. So various progesterones are found. So So now going to the conclusion of recurrent implantation failure. When there is a repeated IVF failure, it will be frustrating for the patient as well as for the doctor. But it is the duty of the doctor as well as to the patient to discuss and analyze the previous stimulations and what went wrong and what could be done to improve the result. As I said, we need to look at other factors for repeated failure. When even after good quality embryos have failed to implant, the main thing what we usually miss is the immunological causes, other autoimmune conditions which might be associated with a failure, or there can be inherited thrombophilias. Giving extra supplements can help, or when advanced maternal age is the reason, or there is a risk of aneuploid embryos, doing a PGTA can help the patient. So the what are the management we do in RIF is check the endometrial receptivity, whether we are transferring the embryos, good quality embryos, in the window period of implantation. There are various test methods to find out the window period of implantation. Either we do a natural cycle or check the endometrial receptivity and then transfer, and then look at the embryo quality. Maybe the stimulation protocol, if we can optimize the protocol and get a better quality embryos, that can help to achieve a result. Next, going to the embryo transfer technique, very meticulous and gentle method of embryo transfer without injuring the endometrium, precisely placing it in the uterine cavity under ultrasound guidance, using soft catheters, removing the cervical mucus, avoiding injury to the endometrial lining. All these simple things can help to achieve a result in a embryo transfer. Next, if there is a problem with the embryo quality, if there is a risk of aneuploidy, even if PGTS says aneuploid embryo, talking to the couple about changing the gametes can help them achieve a result. Same when the endometrium thickness is less, then we give medications to improve the endometrial thickness, other supplements, or see in a natural cycle, and methods to improve the endometrial thickness. It can be even a PRP, using aspirin, sildenafil, and low molecular weight heparin. All this helps to achieve a good thickness. Plus, looking at the window period of implantation, even if it's a 6 or 7 endometrial thickness, if that happens in the window period, then there are chances to achieve a healthy pregnancy. So, recurrent implantation failure, it's a complex problem with a wide variety of reasons for the failure, and various mechanisms are involved as well as the treatment option. So, women with repeated implantation failure should be offered the appropriate investigation to rule out the underlying reason for the failure. Most of the time, ignored ones are the immunological causes, the alloimmune rejection. So that has to be taken care of. The main treatment strategy in couple with recurrent implantation failure is to improve the quality of the embryo transferred and look at the receptivity of the endometrium and then transfer. Identify the factors that are predisposing the occurrence of the RAF will make it possible to individualize the treatment plan. So it is not standardized for every patient. Each patient is individual. So we try to individualize the treatment. This protocol works for this patient, and this is the reason for the failure. Why this patient has not conceived all these years, having a good quality, good number of eggs, good semen, and patent fallopian tube. Is there anything other than egg, sperm, and the uterine cavity causing the failure? That has to be analyzed. Immunomodulatory effects as well as a positive pregnancy outcome or of oral dydrogesterone is an effective option for progesterone support in luteal phase of this patient. Adequate luteal phase support, and if there is an immune rejection, that has to be treated. Thank you.